Hello, friends. My name is Dr. Dhar, and I welcome all of you for this meeting on smoking cessation in lung cancer. I represent the Indian Chest Society, and a very warm welcome to from the Indian Chest Society to all of you. To talk about tobacco use and impact on human health, and I will have some focus on lung health. We would also want to speak about how this is important, how this is relevant in the perspective of lung cancer. However, that would be done as a part of the panel discussion, which you will hear in a little while. So I start off by giving you some data. The most recent data we have is from the WHO fact sheet, and the data is startling. The fact that it kills up to half of its users, and we're talking here about tobacco in all its forms and not just smoking, and the fact that it kills more than 8 million people each year. If you think about other common diseases, heart disease, stroke, etc., you could add all of these common factors together and still have smoking superseding as a cause of mortality. The other startling fact which comes out from this WHO fact sheet is the fact that 80% of the world's 1.3 billion tobacco users live in low and middle income countries. And you understand that the impact on health, the impact on economy is going to be far greater in these low and middle income countries as compared to what it is in the Western world. So this is a two-way whammy. First, from the numbers fact and the mortality, and second, the fact that there's a bias towards the developing nations, towards the low and middle income countries, which makes it of even greater menace. When we talk about smoking, and you understand we're talking here about smoking rather than tobacco use, a question that needs to be answered is what qualifies as being a smoker? We would normally think it's someone who smokes daily. However, there might be others who smoke occasionally. They call themselves social smokers. Once or twice a week, they would say. Some would be ex-smokers, having stopped 5-10 years ago. Some would say, previously I used to smoke socially, now I don't do that at all. And then there would be the never smokers. So out of 1 to 4, what qualifies as smoking? And probably the answer to that is any of them would qualify as smoking. But more importantly, you try and gauge and classify the varieties of smokers that you have. This lovely paper, which came out in BMC Medical Information, tries to enlist and classify smokers depending on 2 factors: whether they are ex-smokers or current smokers, whether their tobacco or cigarette consumption is less than 10 or more than 10, and when they take their first cigarette after waking up. And based on this, they classify these individuals as being light, medium, heavy, and very heavy smokers. I'll not read through this entire slide, but let's do light and very heavy smokers just to give you a ballpark number as to how you classify these individuals. So a light smoker or an ex-light smoker is someone who has a tobacco consumption or a cigarette consumption of less than 10 cigarettes a day or equivalent, and over 60 minutes lapses before they take their first cigarette after waking up. So that's a light smoker. What about a very heavy smoker? A very heavy smoker is someone who's either a current very heavy smoker or an ex very heavy smoker who has tobacco consumption of 40 or more and who takes the first cigarette within 5 minutes of waking up. And medium and heavy smoker are classed in between. So remember these numbers, because when you're writing your prescription out, when you're advising your patient, it might be useful to classify them, A, to counsel them accordingly, and B, the treatment that you give, which will be discussed in great detail as we go along in this meeting, could be actually targeted according to the severity or the grade of smoking. Why do we talk about tobacco smoking so much? Why is it thought to be the greatest menace in the world? And the reason for that is that smoked tobacco seems to be the most addictive substance amongst all other drugs that's used. In this particular study, which came out in a journal of psychopharmacology, they looked at various addictive substances. And you can see on my pointer there, the substances that are mentioned here in our perception, at least in my perception, used to be far more addictive, far more dependence producing as compared to what cigarette is in my mind. So cannabis, cocaine, heroin are on that list. But look at the graph for prevalence of dependence in tobacco. That's the blue line. And you can see that 25 and beyond that, the dependence plateaus off. There's no waning. And that's why the tobacco addiction is thought to be the most potent, the most dependence producing addictions of all. If you look at things like psychedelics, for instance, or heroin, for instance, there's a downward trend, there's a downward graph, or there is a waxing and waning of dependence. And you can catch these areas of waxing and waning or the downward trend in trying to counsel them, in trying to treat them and get them addiction free. With tobacco, the window of opportunity is small, and hence we need to jump in and try again. The ways will be discussed, but I think the initiative has to come from the doctor, the initiative has to come from the counselor in making sure they do this over and over again whenever they meet the individual, and message should be loud and clear. So let's talk about the burden of smoking. We have said that smoking is the single most preventable cause of death in the world. We've also said that the risk factor from smoking is 6 of 8 leading causes of death. So the leading causes of death are in the box here: heart disease, cerebrovascular disease, pulmonary disease, and cancer. So smoking is a predisposing factor for these 4, and 2 others within the first 8 leading causes of mortality in the world. So it increases the risk of dying by itself and also causing diseases which are leading causes of death. So what are the health hazards and what are the benefits of quitting? So we start off briefly talking about secondhand smoke. So passive smoking, as we call it, is equally important. It's no less potent a stimulus for disease as active smoking is. So lung cancer, a risk is increased by 20 to 30%. Heart disease is a similar number, and that's important. Lung cancer and heart disease form the top 2, and then stroke, again, similar numbers. Secondhand smoke exposure causes more than 8,000 deaths from stroke annually. Approximately 700 million children, nearly half of all children in the world, are regularly exposed to secondhand smoke. And children exposed to secondhand smoke are at increased risk of sudden infant death syndrome, asthma and respiratory disease, and ear infection. I believe passive smoking for children is one of the most important things that we should discuss about. Hence, a bit more of facts. These are from the report of Scientific Committee on Tobacco and Health, and also from the Royal College of Physicians document from 1992. Children whose parents smoke have a 1.5 times greater risk of having asthma, 57 to 72% increased risk of respiratory disease, and they inhale nicotine in amounts equivalent to them smoking 60 to 150 cigarettes per year. 60 to 150 cigarettes a year, mind-boggling numbers. And children whose mothers have smoked during pregnancy, much greater chance of developing sudden infant death syndrome, as we said, and about a 1.6 times greater chance of developing a lung infection. So children, your children who smoke passively, your patients' children who smoke passively are at a huge risk of dying or having significant morbidity from their parents having smoked. They're not to blame at all for what happens to them. What about the causal linkage of various diseases to smoking? So on the right of this graph, as you see on my cursor, are chronic diseases, and on the left are cancers. Let's start off with the chronic diseases first. Some of the diseases that you see on there are ones that you would anticipate anyway. So the stroke, the coronary artery disease, the pneumonia, atherosclerosis, COPD, asthma, TB, diabetes are ones you know. But the ones that I'm not reading are important because you wouldn't anticipate that these factors are caused by smoking. Eye problems, so the cataract, age-related macular degeneration, dental problems, periodontitis, reproductive defects in women, including reduced fertility, fractures, including hip fractures. All of these are chronic diseases that are also significantly related to smoking. Let's now look at the cancer basket. The obvious one is lung cancer, and you can see it on there somewhere in the middle, trachea, bronchus, and lung. Maybe esophagus, larynx, and oropharynx, then in the upper part of the airway, the upper part of the body, and they are also obvious causes which are linked to smoking, cancers which are linked to smoking. But then look at the remaining list: the acute myeloid leukemia, the pancreatic and liver cancers, the kidney cancer, the cervical cancer. Mind-boggling. There is hardly an organ in the body where malignant transformation might not happen due to the hazards of smoking. Here we have talked about smoking. Remember, oral tobacco has similar decrements, it has similar problems, and oral cancers, laryngeal cancers, upper airway cancers are as rife with oral tobacco, if not more, as compared to smoking. This is a lovely study which is recent, which is about 6 or 7 years old, which looks at loss of life from smoking cigarettes throughout adulthood. So this study presumes that smoking starts at around age 35, and they follow these patients up to the age of 80 if they survive till that age. This is after the Fletcher-Peto curve, the famous Fletcher-Peto curve, which looked at the problems with smoking, the morbidity and mortality associated with smoking, and then the benefits that you accrued by stopping at different ages. This, however, just compares two groups of people: a group of people who've never smoked and a group of people who have smoked from 35 for their entire lifetime. And I want you to look at 3 different countries and continents which are on that slide. There's United Kingdom, there's the USA, and there is Japan. And you can see that in the UK, men and women, same for the US, men and women, and in Japan, men and women, there's a reduction of lifespan of 10 years when you compare people between those who've never smoked versus those who've smoked from the age of 35 and beyond. A loss of 10 years in lifespan is huge. And the mortality that you attain with cigarette smoking probably supersedes any of the other factors that we spoke about a little while ago. So when do you get benefit from quitting? And this again is a lovely slide which tells you what happens when you stop smoking, what happens immediately, what happens later on. So within 20 minutes of stopping smoking, your pulse rate will return to normal. About 8 hours down the line, that's only 1/3 of a day, the carbon monoxide levels reduce to half, oxygen levels return to normal. 2 days of quitting, carbon monoxide is eliminated. Within 72 hours, so that's 3 days, breathing is better, bronchial tubes relax, so there's better bronchodilation with the smooth muscles of the bronchus having relaxed, and the energy levels increase. 3 to 9 months, lung function increases, improves by 10%. So that's within 9 months of stopping smoking. Within a year, the cardiovascular morbidity is reduced significantly. Heart attacks reduced by half compared to that of smoker. By 10 years, lung cancer risk falls by half. And by 15 years, the risk of a heart attack is the same as that of a never smoker. So starting off within 8 hours, up to 15 years, you accrue years in life, your mortality reduces, your morbidity goes down significantly. Hence, the adage, it's never too late to stop. I'll talk briefly for a minute about the science behind tobacco addiction. This is the DSM-5 criteria for tobacco use disorder. There are 11 criteria on that list, of which at least 2 must be present in the last 12 months for it to be called a tobacco user disorder. If this is an area which interests you, I would implore you, I would request you to go through the DSM-5 criteria, because it at least gives you a mental understanding of factors that you're looking at. I won't read through this list for the want of time. However, there are factors about how much of tobacco and for how long the person has taken it, whether there is actually a desire on the part of the individual to stop smoking or use tobacco or not, whether there have been multiple or single or never effort to stop in the past, how strong is the craving or desire to use tobacco, what are the recurrent users patterns, so whether the person smokes in bed or not, for instance, and multiple other factors. So that's to define tobacco user disorder. And then you have nicotine dependence. Nicotine dependence, according to the World Health Organization, other international societies, are unsuccessful attempts to stop smoking, difficulty to control usage, and previous experience of withdrawal symptoms during a period of abstinence. The withdrawal symptoms are listed there: the mood disorder, the depression, the insomnia, irritability, anxiety. All of these factors make tobacco smoking cessation the most difficult cessation program ever in mankind. A word about deaths and then we'll finish. I want you to focus on a couple of things on there. The fact that lung cancer causes 1/4 of deaths from smoking, COPD caused 1/5 of the deaths from smoking, and other respiratory diseases. And when we say other respiratory diseases, we mean diseases like asthma, interstitial lung disease, etc., caused 1/10. So 1/4 for lung cancer, 1/5 for COPD, 1/10 for other respiratory diseases. But prominent up to 1/5 is also ischemic heart disease. There are other cancers, that there is an impairment in the circulatory system, and even the digestive tract is affected. And these gives you numbers, the number of deaths due to smoking and the percentage of deaths due to smoking in men and women. And you can see respiratory disease and cancers are right at the top as expected in this list. What about fatal diseases associated with smoking? You can see cancer again at the top and COPD, but in the cancer list, there's also tobacco cancer, and there's also bladder cancer. There's also cancer of the esophagus and kidney, which promotes what I told you before, the fact it's not just about the lung, even though the lung is the most important along with the heart, it's also about other organ systems in the body. So I finish off by again underlining the fact that tobacco and smoking is the most addictive behavior known to mankind. This has a massive impact just on lung health, but also every other part of the body. We have tried through the course of this talk to underline how important this is from a morbidity and even more importantly, from a mortality point of view. Quitting is difficult. However, if you do manage to quit, the effects are immediate and you will continue to accrue benefits from stopping smoking after 15 years of having stopped. So lots of incentives for you to stop. You will now listen as to how you go about getting your patients or getting your family or yourself to stop smoking, and then a great panel discussion, which will put it all in the lung cancer perspective. So happy listening, and thanks again from all of us in the Indian Society for having come about with this meeting. Thank you very much.